Good morning, or good afternoon, or good evening, or good night, depending on where you are. Thank you for attending this first medical session. And we try to make these medical sessions accessible to a non-medical audience, but we have world-renowned experts in chronic lymphocytic leukemia, small lymphocytic lymphoma, speaking today. And the first areas that we're going to cover are areas that have to do with the beginnings of CLL. So we're going to be talking a little bit about the diversity of CLL, and that's going to be a very broad subject. And Dr. Versha Banerji, Associate Professor at the University of Manitoba, clinical scientist in cancer at CancerCare Manitoba, Canada, will be helping us with that. That's going to be followed up by the topic of diagnosis and this very important area to understand from a patient's perspective, active surveillance, or what patients call watch and wait, or sometimes watch and worry. Dr. Alina, Gerrie, Assistant Professor of Hematology and Medical Oncology at the University of British Columbia, Vancouver, Canada, will be presenting that. And that's going to be followed by our frontline treatment update. And Dr. Nicole Lamana will be presenting that. She's an associate attending in the leukemia service and the director of the chronic lymphocytic leukemia program there in heme malignancies and at the Herbert Irving Comprehensive Cancer Center in New York in the United States. So the speakers will now begin with the very first session dealing with the issue of diversity in CLL.
Thank you very much for that introduction, Brian. I'm very honored to be here today with you to discuss the diversity of CLL. So as you're all aware, chronic lymphocytic leukemia is a monoclonal lymphoproliferative disorder that is characterized by the following phenotype. These are lymphocytes that carry surface markers that are CD19 positive, CD5 positive, and CD23 positive, and often can appear in greater number on a blood smear, which is shown here, and can be reported on a blood report as a smudge cell. But CLL is not the only disorder that has that phenotype or that pattern on its cells. It actually belongs to a spectrum of lymphoproliferative disorders known as monoclonal B-cell lymphocytosis, chronic lymphocytic leukemia, or small lymphocytic lymphoma. And what distinguishes these entities is really what threshold of these cells are present within the bloodstream and or the location of any of these cells within the body. Monoclonal B-cell lymphocytosis is not considered a cancer, but often carries a lot of the complications associated with a low immune system function. And so in this entity, the blood count is less than 5 times 10 to the 9th per liter. Whereas in CLL, you have more than 5 times 10 to the 9th per liter cells. In small lymphocytic lymphoma, you may not have a high number of blood cells circulating, but you may have lymph nodes that are enlarged or have had a bone marrow biopsy. So who gets chronic lymphocytic leukemia? Here we can see the global incidence of chronic lymphocytic leukemia across many different jurisdictions, including Europe, Asia, and North America. In Europe, what we see here are the incidence, which are the new diagnosis in blue, and the prevalence, which is the cumulative cases of CLL over time. So what we can see here is in what we would consider the Western world, i.e. Europe and North America, the prevalence and incidence of CLL are rising over time. However, in Asia, the prevalence is actually lower than the incidence, and this might be due to many different factors worldwide. So what are the causes of decreased rates worldwide? One, an underestimation due to the decreased availability of routine testing with a complete blood count, which is the most common way most patients are diagnosed with their CLL. Two, decreased survival in developing nations or ethnic groups, i.e., they're not surviving long enough to be part of that prevalent statistic due to socioeconomic or access to healthcare. And the other thing that is often not taken into consideration is different populations might have actually different sex ratios. So there might be more females or more males within certain populations, and that might alter the statistics of the prevalence worldwide. So what is very clear in the data that I presented is that a very large group of patients is excluded, and that is the African subcontinent and the African American population that we'll talk about in this next slide. And so part of that is we don't have accurate information, or we have pockets of information coming from different countries, but nothing cumulative from the continent as a whole. So this is a study that was recently published to look at the incidence of monoclonal B-cell lymphocytosis and CLL in patients of European ancestry versus patients of African American descent. And so I just put this up to demonstrate sort of the statistics about the sex, and about the age of the patients. And so if we look at the sex, we look at the male proportion. So across most of the diagnoses, this tends to be a male predominant disease. But what I wanted to point out, though, is that if we look at the median age of patients, you see here in the European ancestry that a lot of the patients are older. So median age of MBL overall is 70, of CLL is 62. But if we look at the age of CLL patients, even in this small cohort, their age is much younger. So the other thing to note is that the age spans are quite similar, but it might be that African Americans or patients of African ancestry may develop CLL earlier. So these are things that we have to keep in mind as clinicians that are taking care of patients from different backgrounds as to who is likely to develop this entity and at what age in their life. And so this is all things that we're learning as more data becomes available. The other thing that we wanted to discuss is how does the geographic change in population affect the diagnoses within a different nation? And so North America is really built on immigration patterns. And so if we look at CLL incidence over time, what is clear is, although not as prevalent as we expect, we are starting to see an increase in the prevalence of CLL in other populations outside of the European ancestry or white population. And so the rate of a patient developing CLL is highest in the non-Hispanic white population, and then is significantly lower in the Asians. But this is something that has been studied even over time. And it seems like as patients move from their country of origin to North America, that there might be factors within the environment that influence the development of CLL in those populations. And so I think we're going to see, as areas become more multi-ethnic, as information is collected over time and as those populations establish themselves, the ability to capture more information on what is the true impact of the diversity of humans as a whole and the development of CLL. And then finally, I wanted to talk a little bit about women. CLL has always been portrayed as a disease of elder men. And one of the things that I've seen in my practice is a lot of young women. And so I think I wanted to bring to the attention of patients and validate that there are a lot of women that are diagnosed with CLL. And a lot of times those women are young. And so we have to understand how the diversity among sex is represented in this patient population. And so there's been a study that looked at the development of monoclonal B-cell lymphocytosis in the Women's National Health Study. And so this is where they just took women over time and followed their blood counts. And so they were able to see the rates of development of monoclonal B cell lymphocytosis. I should point out that monoclonal B cell lymphocytosis isn't necessarily a CLL specific finding, but does represent a proportion of patients that develop this. So that's the caveat in this slide, that this is not everyone that goes on to develop CLL, but to show that if you take women in different ethnicities and in different age groups, the likelihood of them having an MBL can be quite common. So if we take white women, their incidence of developing MBL actually is much later in life. But if you take African American or Hispanic women, their incidence of developing MBL is much earlier in life. So this follows with what we see clinically of women who are developing CLL at earlier ages, but it is important to know that that might be skewed by the health of that individual and their ethnicity. So the next thing I wanted to touch on was moving away from the epidemiology of CLL to another form of diversity, which we can term molecular heterogeneity. So CLL really isn't just one disease. It does represent a conglomerate of different entities that are really personalized and unique to each individual based on the underlying biology of their condition. And so the molecular heterogeneity really is a understanding of how the cancer cell is trying to maintain its balance from a growth and death perspective. So we have genes in our system that are responsible to be the brakes and the gas pedals to maintain a balance and a life cycle of cells that are dying and surviving. So if we lose a tumor suppressor gene, i.e., we lose the brake, then we are having cells that have uncontrolled growth. If we put our foot down on the accelerator and the brake can't stop, then we're further accumulating that growth signal. And sometimes the accelerator can overpower the brake itself and render the brake non-functional. And so as a result, we have different people with different CLL subtypes that may do differently. And this is important to understand as well. So how do we detect this molecular heterogeneity? One of the tests that we use is something called fluorescence in situ hybridization, which is often referred to as FISH. It has the ability to detect 4 different chromosomal abnormalities. Now, your chromosomes are where your genes lie, and basically we can detect different losses or gains of these chromosomes. And so the most important loss that we're looking for is 17p deletions, which is the most aggressive form of CLL. And so it actually does predict how patients do when they are treated with standard treatments of an era that is quite past. So a lot of the data that we have now is about how patients with these molecular abnormalities do when they were treated in the realm when chemotherapy was the only treatment options we had. So this data does not represent the now of CLL, but does represent the building blocks that we're trying to improve on as we develop new treatments for CLL. So what we can see from this busy graph is the different molecular abnormalities: 13q deletion, no evidence of any abnormalities, a trisomy 12, an 11q deletion, and a 17p deletion. And what we can see here are what are called survival curves. And so the higher the curve, the better the patient's survival. The lower the curve, the worse the patient's survival. And so the 17p deletion really identified a patient with an unmet need, and why new treatments were needed to help support not just these patients, but also the patients that may not have done with even some, not even done well with some of these good prognostic markers, because they may have other abnormalities in addition. So what are these other abnormalities? So we can now test for something called the P53 mutation. So instead of just looking at a break in a chromosome, the patient's chromosome might be intact, but we now have the ability to dive down to the gene level to look to see if the sequence of the nucleotides which make up the gene are normal. But if they're not, they might have a mutation. And that mutation means that that gene can't make the protein that helps with the breaking of the cancer cell. And so this is something that we are now able to identify. And it's not that a lot of patients have this mutation at the very beginning of their disease, but can accumulate it over time, especially when they were treated previously with chemotherapy. So the FISH and the P53 mutation testing are tests that are often done in some places at diagnosis, but in Canada, we do it prior to treatment because it influences our treatment decision. These are patients that shouldn't receive chemotherapy. The other group of testing that is done is identification of the IGVH mutational status. The IGVH unmutated patient is in the general population 40% of all CLL patients, but in the treated population 60% of all patients. And this is because the unmutated phenotype is considered a immature B cell. And so it often pertains poor prognosis when treated with chemotherapy in the past. However, as I said, things are changing so rapidly that we now have effective treatments for our highest risk patients and our patients with the IGVH unmutated status. And so we are now in an era where we're trying to improve upon these great leaps and strides we've already accomplished to get the best personalized treatment for every individual. So one of the things that may not yet be clinically relevant, but is important for any patient with CLL to know is the tests that I talked about previously are the tests that we can act on now. But we're in the process of understanding the growth and development of CLL biology that might be able to help different individuals, not only with the treatment of their CLL, but also with the diagnosis. Because some of these mutations that are in the CLL patient are definitely something that accumulate with time, but they also might help distinguish one entity versus another from a diagnostic perspective. So we're able to expand our testing to include gene testing that might help say, oh, this is definitely CLL and not something else. But the other thing that it's helping with is identifying patients that even with our novel treatments may benefit from additional information that would define what treatment they would use, and two, how long they should be treated for, and three, should we stop treatment? So these are all things that are now entering the sphere of CLL treatment, but is really important in patients' management and understanding of the CLL entity. So this touches on what does this mean clinically. And so I think one of the things that we didn't understand was how gene mutations and the FISH testing lead to information that could influence outcomes. And again, this information would be in the era of chemotherapy. And so what we found was the survival of patients with 13q deletions was always considered the best of all patients. It's a good prognostic indicator. But if that's paired with a mutation in Notch SF3B1 or an 11q deletion or a P53 mutation, then this could lead to a worse outcome. Given the treatments have changed drastically from when this information was generated, we now are starting to learn how this information is being integrated as a whole. And so with this, we're entering an exciting era of CLL diversity and how it can help personalize every single person's care. Thank you.
Hello, I'm Alina Gerrie, and I'm a hematologist at BC Cancer in Vancouver. I come to you from Vancouver today, which I acknowledge is on the ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and I'm privileged to be able to work and live on these lands. I'm really thrilled to be able to talk to you today about CLL diagnosis and active surveillance. It's important to discuss my disclosures. I have received institutional research funding and participated in advisory boards and received honoraria from the companies listed here, primarily related to CLL research and drug development. In terms of outline, I'll be talking to you today about how CLL is diagnosed, what tests need to be done and what tests do not need to be done, which genomic tests should be offered. This is an area of interest. I'll also discuss what active surveillance actually means, and a question that I often get, or I'm sure that as patient advocacy groups you likely get from patients, why won't they treat me? Or why won't you treat me, doctor? So for this presentation, I'd like you to imagine that you are a 68-year-old gentleman. You're healthy and well, you're actually a runner, and you have a knee injury and you see your family doctor or general practitioner and you've been referred to a surgeon. But before you get referred, your doctor says, let's just do some routine blood work. And then you get a phone call from your doctor's office asking you to come in. And when you come in, they tell you that you have leukemia. Obviously, this can be devastating. A lot of fear and anxiety associated with this word in particular. And my hope for this presentation is to give you some basic background information so that you as patient advocacy groups can help support patients as they go through their journey, their initial journey with this diagnosis. So chronic lymphocytic leukemia is a cancer of a type of white blood cell called lymphocytes. That's where the term lymphocytic comes from. It is a slow growing cancer, which is why it has the term chronic. And patients with CLL typically have high lymphocyte counts in their blood. And this can be detected from an easy test called CBC, or a complete blood count. In a normal patient, a lymphocyte count is somewhere between 0.8 and 5. Whereas in a CLL patient, according to diagnostic criteria, the lymphocyte count is greater than 5, but it can be 50, 100, to even 200 and 300. So it can be very, very high. We also look at the blood under a microscope in a test called a peripheral blood film. And this is not exactly what it looks like, but a bit of an idea. In a patient with healthy blood, you'll see mostly red blood cells in there. And then you'll see a few of these purple or pink cells, those are white blood cells. And then the yellow ones in this picture are platelets. In a patient with CLL, you can see that the normal red blood cells are sort of crowded out. There's fewer of them, and there's many more of these white blood cells or lymphocytes, and fewer red cells and platelets. And that's really typical of a patient with CLL. So how do we know, though, that the high lymphocyte count is actually CLL cells and not something else? And that's where we do a test called flow cytometry. So again, this is, we take a blood sample from a patient, and the blood cells are put through a tube where a laser light source is shone on the cells. And depending on what markers or proteins are on the cell surface, the light will scatter in different directions. And it creates a picture for the pathologist or technicians to look at and read. And they can essentially confirm that the high lymphocyte count in a patient's blood are actually due to CLL cells based on the specific pattern of markers that are seen. And some of the common markers that we look for, you might hear these terms, CD19 and CD5. Those are some of the common ones to help diagnose CLL. So what about a bone marrow aspirate and biopsy? These are actually not typically required at diagnosis. They might be done in some certain situations or if something's a bit unclear. And they're often done prior to a patient starting therapy. These tests can be done either with a patient lying on their side or lying on their stomach. And we use a needle to freeze the skin and the area of bone just in the top side of the hip here. And then use a larger needle to go in and take out part of the fluid or the blood essentially that runs through the marrow. That's called the aspirate. And then we take a tiny sliver of the bone itself, and that's called a biopsy. This procedure can be uncomfortable, and patients are often very anxious about this procedure. We can give pain medication to help, and in some centers it's done under conscious sedation. We don't do that in my center, and I don't think in many centers in Canada. And people will have some pain in the area, maybe need some Tylenol for a day or two afterwards. So what about small lymphocytic lymphoma? So this is a different form of CLL, where it's the same abnormal lymphocytes. So if we do flow cytometry, they have the same markers on the surface, but this time, instead of being primarily in the blood, the cells are primarily in the lymph nodes or organs. We have lymph nodes throughout our body, and the main areas we can feel them are in the neck, under the arms, and in the groin. And here there's a picture of a pretty classic presentation of a patient with lymph nodes in the neck. And we see this with SLL, small lymphocytic lymphoma, and also CLL. Patients with CLL can also have lymph nodes. It's just that in SLL, the white blood cell count and lymphocyte count are normal. For SLL, you do need some kind of lymph node or tissue biopsy for diagnosis. Sometimes it is a bone marrow biopsy. And often patients will get CT scans or even a PET scan to help determine the distribution of lymph nodes throughout their body. So what about genetic and genomic testing? This type of testing is not actually required at diagnosis of CLL because it doesn't really change what we do for the initial management. However, it is very useful for prognosis. So many patients do want to have these tests done at diagnosis, and it can really help inform, give them a sense of what the disease will be like for them, what their illness will be like, potentially be like over the next number of years. Cytogenetics refers to testing of chromosomes, and we can detect them by a test called FISH, where fluorescent probes are placed on different chromosomes. And again, depending on the pattern that the pathologists see under a microscope, they can tell if certain abnormalities are present. And the main ones we look for in CLL are deletion 17p, deletion 11q, trisomy 12, and deletion 13q, ranging from deletion 17p being associated with a poor prognosis and deletion 13q being associated with a good prognosis. Karyotyping is a bit more complicated way to look at all of the chromosomes in a patient. And then we can do gene sequencing, including for gene mutations such as TP53, which is closely linked with deletion 17p and is associated with a poor prognosis. We can do a test called IGHV mutational status. A little bit of a complicated name. It stands for immunoglobulin heavy chain variable region mutational status. Immunoglobulin means antibody, and normal lymphocytes, their job is to produce antibodies. So CLL cells also produce antibodies. This is a picture of an antibody here. And in blue, this is what's called a heavy chain. And at the end of the heavy chain, there's an area called a variable region. And it's variable because it can mutate. So CLL cells that are more mature, as they grow, they can mutate. And if they're more mature, mutated, these types of CLL patients it's associated with a better prognosis compared to those who have unmutated IGHV, which is associated with a worse prognosis. And then there's other genes that have been implicated in prognosis that some places will test for. The main three markers that are of importance are deletion 17p, TP53 mutation, and IGHV mutational status. And these can not only tell us about prognosis, which means survival, how well patients will do with their CLL, but also can predict how patients do with treatment. And one of the main big issues for CLL globally is that access to these tests is limited in many centers. So for example, in my center, in my province in British Columbia, in a publicly funded system, we actually have really good access to FISH testing, and we can do all 4 tests for patients, even at diagnosis and prior to treatment. Only in the last few years have we had access to IGHV mutational status testing, and not everywhere in Canada has that testing available. And people often send it out to other parts of the country. And many centers do not have, including mine, do not have access to TP53 mutation testing. And that's something we're definitely advocating for in our province. So what do the guidelines say? I focused here on 2 main guidelines, the International Workshop for CLL Guidelines, which were last updated in 2018, and the European Society of Medical Oncology Guidelines from most recently from 2021. So you can see at diagnosis, really for CLL, the only 2 tests that are required are CBC and flow cytometry. For SLL, patients would need some kind of actual tissue biopsy. In terms of doing FISH for deletion 17p or molecular testing for TP53, for diagnosis is not recommended in the IWCLL guidelines. And in the ESMO guidelines, there is a comment that if a patient requests prognostic testing, that would be reasonable to do. And I think it is very important for patients to have this information. And this information does tie into a lot of our prognostic scores and is helpful as the physician looking after the patients to have a sense of how their disease may go over time. When a person gets to a point of needing treatment, the main tests that we ideally would like to do are testing for FISH, and the ESMO guidelines specify really deletion 17p being the most important if you did have to pick and choose. TP53 mutation testing, IGHV. And then in terms of imaging, IWCLL recommends a chest x-ray and possibly abdominal ultrasound, which is a great way to monitor size of spleen and liver. And CT scans don't necessarily need to be done. I find they're being done more and more, especially as we have more clinical trials available. And for certain drugs like venetoclax, they are important. And certainly if patients have symptoms and you're trying to sort out what they're due to, that would be a reason to get more imaging. So as I mentioned, CLL and SLL are a spectrum of the same disease. Patients can have a number of symptoms, including fatigue, shortness of breath, often related to anemia, weight loss, bleeding, bruising, infections. People with CLL are immunocompromised. So even though the white blood cell count is very high, these are abnormal white blood cells. They're not working properly. So they can have fevers, infections. However, many people, when they're diagnosed, such as our patient here, have absolutely no symptoms. And it was found usually because they were having tests done for something completely unrelated. And we call that asymptomatic. In terms of treatment, it's important to think about the goals of therapy. So still today, CLL is an incurable cancer. There's a lot of research to try to search for a cure for CLL, and we're hopeful that will come. But apart from a very small group of patients who undergo an allogeneic stem cell transplant, CLL remains incurable. So our goals of therapy are not to just treat the disease right away and get rid of it, to cure it, but to do what we can, whatever it will take to prolong the amount of time people survive, prolong survival, and improve quality of life. So a number of studies have shown that early treatment does not prolong survival and may in fact worsen quality of life due to side effects. And if patients receive drugs early, they could develop resistance, and then we would not be able to use them when their disease progresses. So all of the guidelines that are out there, and there's a number, not just the two I mentioned, but all of the different guidelines out there recommend active surveillance for patients without any symptoms. Active surveillance has many different names. You might hear about it as watch and wait. Watch and worry is another term. People call it monitoring, observation, and many people feel like we're actually doing nothing when they're on active surveillance. And this can lead to anxiety, fear. Comments I hear from patients are that it feels like their life is on hold. They feel like they can't plan for the future. So what can we do to help them through this period of their treatment? I think it's important to understand what active surveillance really means. Usually patients are reviewed by a medical professional about at the beginning once every 3 months, and then that tends to get extended to once every 6 months or once a year, once you get a sense of the pace of the disease. We do a CBC, a history and physical exam, monitoring for the symptoms that I've mentioned, and also monitoring for more rapid rises in the lymphocyte count. And I think importantly, these visits are also an opportunity to promote general overall health, including the importance of exercise, nutrition, mental health supports, and preventative medicine, in particular, cancer screening, because patients with CLL are at higher risk of developing secondary or other cancers, as well as immunizations, a hot topic right now with COVID-19, and I think you hear more about that tomorrow. But really, these are great opportunities to talk about these things and to advocate for preventative services in your area. And patients are really an active participant in this part of active surveillance. And once symptoms appear, that's when we start the discussions about or start to consider what treatment we would administer. So what can we do to support patients? I think at diagnosis, education is really key, both things we can give patients when we see them, but also now in the age of the internet, different resources, make sure they get clear educational resources and have open communication with various groups. We want to ensure they have psychosocial support, peer support, and then really advocating for testing for some of those prognostic markers that may be limited in other areas. During active surveillance, it's really important to educate about the reasons for active surveillance and to have the patients be active participants in this. Again, psychosocial supports, encouraging healthy lifestyle, and really optimizing preventative care. And then advocacy for access to drugs when the patients need treatment, clinical trials, and other research initiatives as much as we can. So back to this, my patient, he was asymptomatic at diagnosis. I was able to do IgVH testing, and he has an unmutated test, and trisomy 12 by FISH, so this would be an intermediate prognosis. I don't know his TP53 mutation status, and I followed him every 3 months for the first year, and then slowly we've increased that to every 6 months, and it's now been 4 years, and he's still running and doing well. And I really use that opportunity at these medical visits to reinforce preventative medicine and education so that if and when he is at the time of needing treatment, we'll be ready to go and he'll be in the best shape possible to go ahead and receive treatment. So with that, I'll end, and I look forward to the live Q&A. Thank you.
First, I want to thank the organizers for having me talk today. My name is Nicole Amana. I'm a leukemia physician at Columbia University Medical Center here in New York, and I'm going to talk today about frontline or first treatment for patients with CLL. Here are my disclosures. So I know one of my colleagues spoke earlier, but when we talk about when to treat, this is a chronic disease, and so there are criteria that we set forth for when patients have what we call active disease. And usually, typically, this is when patients develop worsening of their good blood count. So if they become anemic or their red cell count gets low, they might feel more tired or fatigued, particularly when they're doing activities. If their platelet count were to get low, they might have more easy bruising or bleeding. If they've developed massive progressive splenomegaly or big bulky lymph nodes, that might occupy space and make them feel uncomfortable, or they might lose weight because of that. We typically won't treat somebody just because they have an elevated white count or lymphocyte count, but if they rapidly rise very, very quickly, the likelihood is that their marrow is getting more involved with their condition and their good counts will decline shortly thereafter. So a rapidly rising white count typically is something we'll pay attention to very closely because they might need treatment very soon. And then some patients develop extranodal disease. So there might be leukemia in their skin or their kidneys or their lungs that need therapy. And oftentimes when patients progress, they have other constitutional symptoms such as fatigue or night sweats or fevers or feeling of general malaise. And so these are all reasons based on the International Working Group criteria about when we think about initiating therapy for somebody with CLL. Now, when we talk about evolution of CLL therapy, we've come a really long way with therapies, thankfully. And we had in the era of the 1950s, we talk about older therapies such as the oral alkylator agents, chlorambucil and cyclophosphamide. And then we fast forward to the 1990s when the purine analogs came along, and that's this drug fludarabine. We also had pentastat and cladribine. And then what really changed therapy in the late 1990s, early 2000s was this monoclonal antibody called rituximab. And that really became added to the backbone of chemotherapy. And this was the chemoimmunotherapy era. And we'll talk more about this going forward, but really was gold standard for younger, fitter patients with CLL. Fast forward now, more recently, we've had other drugs approved, bendamustine, which is also sort of a hybrid between an alkylator and a purine analog, so more aggressive chemotherapy, and then other monoclonal antibodies besides rituximab. Obinutuzumab is probably the most other commonly used CD20 monoclonal antibody. And then in the last 10 to 12 years, we started developing the B-cell receptor pathway or novel targeted treatments, and that's where we're going to center most of the discussion today, was on these newer agents, the BTK and PI3 kinase inhibitors. So ibrutinib, the first to market in 2013, PI3 kinase idelalisib was approved in 2014, and then our BCL2 inhibitor venetoclax approved in 2016, and others shortly thereafter. And these have really revolutionized the way we treat CLL, and I'm going to focus on the approvals and some of the data surrounding these novel targeted therapies. I like to show this little cartoon, this schematic, because this is a B cell, and it also shows some of the older treatments that we've used and where they've sort of targeted in terms of the actual killing of the lymphocyte. And so here you have this B cell, and here's our classical damaging DNA drugs such as fludarabine and penstatin and cladribine, bendamustine and chlorambucil. And then you have here, this is the B cell receptor. And really, this is this multi-complex protein that sits on the surface of the B cell. And you see these proteins have been, are now targeted, have been nice targets for all these different therapies that have gotten approved or currently in evaluation today. And really, the B cell receptor is, it's important for, the proper development, B cell development, differentiation, proliferation, and so on of the B cell. And so here we now have all these nice targeted therapies. Here's the B cell receptor pathway inhibitors, ibrutinib targeting BTK. These are the two that are currently approved and many down the pike. Here is the PI3 kinase inhibitors targeting PI3K here. Idelalisib and duvelisib approved for CLL. Copanlisib approved for follicular lymphoma. Here we have SYK inhibitors not yet approved, but have been in development in clinical trials as well. And then when we talk about cellular therapies, such as CAR T cell therapies, here, T cell therapies that are linked to a virus and then can target CD19, another protein on the B cell. And here you have venetoclax, which is a BCL2 inhibitor for an anti-apoptotic protein, which is approved for CLL. There's also development of MCL1 inhibitors. And then the monoclonal antibodies, again, not so new. Rituximab, the oldest and most traditionally used, but obinutuzumab is a newer one that has been used targeting CD20. And we also have now agents targeting CD37 in development. So really, we've such a plethora of agents that we can use to treat CLL. I want to talk a little bit about the guidelines that we have in the United States, and these are National Comprehensive Cancer Network guidelines that actually cover all cancers, so not just for CLL patients, but even other cancers, and sort of they're what the FDA approvals of drugs that are approved for that particular cancer. And what's interesting is there's been a shift, and the reason why I share this is there really has been a change in the last couple of years of the guidelines for patients with CLL. So whether a patient is older or younger, but they're frail and have significant comorbidities, if they're younger without any comorbidities, or if they have disease features that are otherwise what we consider high risk or not as good, and this is this TP53 mutation or a deletion 17p, and I know one of my colleagues spoke about this earlier as well, that the preferred treatment options for any of the patients with CLL are really now focused on the novel targeted agents that I just showed you in the nice cartoon, and that actually chemotherapy or chemoimmunotherapy is no longer listed under the preferred treatment options. And in fact, there are many pages of treatment options, but they're considered in other. And so the category 1 or preferred treatment options are really the novel targeted treatments that are now available. So given all these different treatments, how do we choose between different therapies at the time that somebody needs treatment? So we look at the patient's age and their functional status. So comorbidities are important, their renal function, their cardiac function. Patient preferences is now more important. So their convenience, what is their social support? Can they get back and forth to the medical center? Certain therapies may require more clinic visits than others, and are they able to do that? Toxicities of therapies, they may hear about certain toxicities and not prefer a certain therapy. And then we're going to talk about this notion of continuous medication versus time-limited therapies. And then disease characteristics are certainly always been important to us. We just had less options way back when. But we look at high-risk features versus non-high-risk features. And some of these features really tell us which therapies we really should be avoiding and how we've changed standard of care for the patients with CLL. And I'm going to talk a little bit about that. So what are the options in 2021? So when we talk about therapies today, we talk about chronic continuous therapy. So with BTK inhibitors, so this is ibrutinib or acalabrutinib that I showed you on the cartoon, and there are others coming down the pike. And this is oral medication. So they take it daily, chronic, indefinitely until they have progressive disease or they have a toxicity that we can't ameliorate. Sometimes this can be combined with a monoclonal antibody, either rituximab or obinutuzumab, which is an intravenous medicine. But for the most part, if somebody's going on chronic continuous therapy, they're going to take a BTK daily. Then we also have an approval of what they call a time-limited therapy. So this is an oral medicine, the BCL2 inhibitor venetoclax, combined with that intravenous monoclonal antibody obinutuzumab. This is only 12 months in duration. So patients will get this therapy, take it for 12 months, and then come off therapy and be monitored until such time point that they might need treatment again. And we're going to talk a little bit about that. And then, of course, we're going to delve a little bit into the future of some of these time-limited approaches and combinations. Chemoimmunotherapy, as I showed you earlier or alluded to, and I'm going to talk more about it, is really not being used much often anymore. And as I showed from the NCCN guidelines, we're sort of not the preferred treatment anymore for patients with CLL, regardless of age or comorbidities. But who should still receive chemoimmunotherapy? And so we'll talk a little bit about that. And then clinical trial options, of course, varies by where that patient might be receiving their therapy. And for some individuals, their only ability to get some of these novel targeted therapies happens to be on clinical trials. Otherwise, they would not be able to get some of these therapies unless part of a clinical trial, maybe because of cost or inavailability of the drug, depending upon where one is globally. So let's talk about chronic continuous therapies with BTK inhibitors. Ibrutinib and acalabrutinib are approved, but there are others coming down the pike. And this was, I'm going to show you just a little bit of data because I think it's important to see where we've come from and why. So this was one of the studies that led to the approval of ibrutinib, the first to market, versus chlorambucil, which is an oral alkylator treatment, gold standard therapy for patients who were older and frailer with CLL. That was the gold standard. And so ibrutinib continued chronically versus chlorambucil, which is usually given for a year. And in an older, frailer patient population. And here now we have some nice long-term follow-up of this data. And for patients over 7 years on therapy, there's a difference in what they call the progression-free survival. And what is that? That means the time that the patient started therapy to either progression of their disease or death. And so patients who received ibrutinib, that's that orange curve, did far better than patients who received chlorambucil. So again, some data, randomized data, suggesting that chemotherapy not as good anymore as some of these novel targeted therapies. Now, acalabrutinib is the other BTK inhibitor that was also approved for CLL. And similarly, in another randomized study looking at acalabrutinib in older, frailer, or patients who had other comorbidities, looking at acalabrutinib plus or minus that monoclonal antibody obinutuzumab versus obinutuzumab and chlorambucil. That combination that's also was a gold standard for older, frailer patients with CLL, chlorambucil, obinutuzumab. And so again, the progression-free survival of patients far better in the acalabrutinib arms here compared to the chlorambucil obinutuzumab arm. So again, another data point suggesting a move away from either chemotherapy or chemoimmunotherapy, the chlorambucil obinutuzumab with targeted therapies because patients are doing better. Now, what about the approval of this targeted time-limited approach with venetoclax and obinutuzumab? This is our BCL2 inhibitor that's been approved. And this is the randomized trial, the international randomized trial that led to the approval of this combination. And this, again, in frailer, older patients that were untreated, they were randomized to either getting venetoclax or obinutuzumab, and this is a year of therapy. The obinutuzumab is intravenous, and you get 6 cycles of treatment. Chlorambucil obinutuzumab, a year of therapy, and again, 6 cycles of the obinutuzumab, which is intravenous. And again, here, the progression-free survival better for the venetoclax obinutuzumab versus chlorambucil obinutuzumab arm. And again, this is time-limited therapy. They're on it for a year, and then they're monitored thereafter. Now, what about chemoimmunotherapy for younger patients? So I said that chlorambucil and chlorambucil obinutuzumab were sort of the gold standards for older, frailer individuals who had multiple medical problems with CLL. But we had a more aggressive chemoimmunotherapy combination with fludarabine, cyclophosphamide, and rituximab, or FCR, for younger, fitter patients with CLL. And this is probably the only time I will talk more about chemoimmunotherapy, perhaps still for some patients with CLL, is that there's data that goes, since this was a gold standard for younger, fitter patients, we have about over 20 years of data for FCR. And so from an old data set from our colleagues at MD Anderson, they were able to go back and look at those samples. And now that we've learned more about the biology of CLL, they were able to separate patients with what they call good risk features to their disease versus others. And so for patients who had what they call a good prognostic marker, it's called a mutated IGHV. This is the blue curve here, that there's a proportion of these patients who at 20 years are still in long-term remission after receiving a time-limited combination of FCR. So again, a very small proportion of patients who are good risk might still be applicable for this therapy, but they're younger, fitter. This is aggressive chemoimmunotherapy. And this is where I might still talk about a little bit, where I might still talk about FCR to a patient who is young and fit and has good risk features. But this is not the majority of patients with CLL because the median age is in the 70s. So bear that in mind. So what about patients with high-risk disease, patients who have features that are not considered good? And this is a 17p deletion or a TP53 mutation, or the unmutated patients with IgHV. And so we now have data emerging that patients on these novel treatments, such as the BTK inhibitors and BCL2 inhibitors, do also far better with these newer treatments compared to chemoimmunotherapy. Back in the day, patients with deletion 17p, their median survival was just a few years. Now with drugs like ibrutinib, look at this data. You know, here, this is work done by our colleagues at the NIH, that the patients now have not only a longer progression-free survival, their overall survival is better, far surpasses what we used to do with these individuals with chemoimmunotherapy, such as chlorambucil or FCR. Similarly, with the venetoclax obinutuzumab combinations, these patients also did better compared to chlorambucil obinutuzumab. So this is a game changer. So for patients with high-risk features to their disease, so it's important to test and know that. These patients do better with novel targeted therapies. And in fact, many of us we wouldn't even consider chemoimmunotherapy for patients with high-risk disease anymore. So this has changed the standard of care for those individuals. Now, what about that mutational status? And so for patients who are unmutated, that was less favorable. Even with the novel targeted treatments, they do better now. The unmutated folks act almost like the good risk folks, like the mutated folks. So again, this group of patients, we would also not consider for traditional chemotherapy or chemoimmunotherapy anymore either. So knowing patients' disease characteristics, we would guide them and say, you know, chemoimmunotherapy is no longer acceptable for you based on your disease characteristics. Now, what about the future direction for patients with CLL? Where are we going? We have these great treatment options that I just showed you. We're learning more about the biology of the disease, but we're also being able to test patients' residual disease at much more sophisticated levels than we were previously, even 10 years ago. And so now we're looking at what they call minimal residual disease, or microscopic levels of their leukemia cells. And we're using some of these techniques to help guide rational combinations of different treatments in newer clinical trials going forward. So venetoclax is an interesting drug, and this is where this minimal residual disease concept is being tested the most. And the reason being is when we first started looking at this drug in patients with relapsed leukemia, what we noticed is it had a really good ability of mopping out the bone marrow disease in patients with CLL. And so patients could go into complete remission, meaning no evidence of the disease in their bone marrow, when receiving venetoclax far quicker than they did with just a BTK inhibitor like ibrutinib or acalabrutinib alone. And so when we looked at that and added a monoclonal antibody, this is why you could do a time-limited approach with a drug like venetoclax, because you can mop up the disease, get rid of it, and patients could then be monitored off therapy. So we started looking at this in some of the combination trials that led to the approval, such as the venetoclax obinutuzumab. And you can see that we're getting so good at testing what they call undetectable minimal residual disease, no evidence of the leukemia, by sophisticated testing and assays that are getting better and better over time, looking for microscopic disease. And if you have undetectable disease, your response duration, the time off of therapy, is typically longer than somebody who might still have minimal residual disease in their bone marrow. And this is even far better than patients who got chemoimmunotherapy. So take that moving forward is now we're looking at combinations of taking our two potent treatments, BTK inhibitors and venetoclax, and combining them as an oral combination. And so hopefully this will be approved in the near future for patients with CLL. So looking at like a plus venetoclax or any of the BTK inhibitors as a time-limited option as well. So 12 months or maybe 24 months in duration of oral combination, no intravenous. They have different mechanisms of action, and perhaps they might even be better treatment for patients with high-risk disease. So some initial work at looking at oral ibrutinib venetoclax was data that got published by our colleagues at MD Anderson, looking that when they looked at people's bone marrow and their residual disease, that over time, the levels of undetectable microscopic disease, that there was a higher proportion of patients with no evidence of disease in their bone marrow over time. Really, the depth of remission was getting greater and greater on therapy. So going forward, now there's an international study looking at oral combinations and using minimal residual disease to help guide us with how long somebody should maybe receive one of the therapies. Can you stop therapy? Does it, when might be appropriate depending upon that patient's disease characteristics with CLL? So here you have the Captivate study, which patients receive ibrutinib and venetoclax for a year, but then they're randomized based on whether or not they have any minimal residual disease in the bone marrow. If they have no evidence of disease, they'll either be on a placebo or continue ibrutinib to see if it matters. Or if there's detectable minimal residual disease, they'll continue either ibrutinib or the combination of ibrutinib and venetoclax. And again, the goal is to see how patients do, and can minimal residual disease testing help guide us in terms of when certain patients might be rationally able to stop therapy, and that might be partly dependent upon their disease characteristics, and where other patients might benefit maybe from being on treatment longer. And so we're trying to use some of our techniques or our testing as we get more sophisticated with how to sort of guide therapies in the future. And then there's a fixed duration cohort that will have 12 months of therapy for everybody, and then they'll be monitored. And we'll see if there's any difference ultimately in progression-free survival or in survival of patients with CLL. So just to summarize, frontline therapy in CLL 2021, where are we today? So we have chronic continuous therapy with the BTK inhibitors, such as ibrutinib and acalabrutinib. And this is really appealing for older patients, less clinic visits, particularly during COVID when you didn't want patients coming into the center a lot. This was the BTK inhibitors were a good choice for some of these individuals. It tends to be the preferred treatment for patients with a higher risk disease, TP53 or 17p deletion. Time-limited approaches, such as with venetoclax and obinutuzumab, tend to appeal for the younger patients only because the patients need to be monitored more intensely for the first month or two when they start this combination therapy. And so if an older patient has more difficulty coming back and forth to the center, they may not choose to do that. It's not that an older person couldn't do that, but they need to have that extra support because there's definitely more monitoring involved with venetoclax. Also, the appeal of a time-limited approach, of course, is that there's decreased long-term costs. You're not on a chronic continuous daily medicine for years. You have 12 months of therapy, so decreased overall costs to the medical system and potentially for the individual patient. Chemoimmunotherapy, as I alluded to, far less use of chemoimmunotherapy. Again, I relegate this to a conversation with generally young, fit individuals with good risk features who might consider FCR. However, I think that the novel therapies will do just as well long-term for their disease, given how well they do with the patients with the most aggressive features that we know. It's just that we don't have 20 years of data with the novel targeted therapies just yet. And then future directions, of course, we're looking at these fixed duration combination choices, the oral combinations, or oral other combinations, with the goals of deep remissions, long progression-free survival, and hopefully an improvement in overall survival. And at some point in time, somebody might need to be retreated at progression down the road. What's important is obviously how are we going to utilize minimal residual disease testing, and how can we help inform treatment decisions for our patients? And hopefully, as we have sophisticated testing that gets better over time, we can share that and make meaningful impacts to treatment options depending upon somebody's disease characteristics. And then, of course, it's always important that we increase the availability of all these therapies and have standardized testing for these patients' disease characteristics, which sometimes influence treatment based on the availability of the testing globally. And so we know that some patients aren't getting the proper testing, nor do they have the available therapies that are available to treat CLL that I just presented for you today. That being said, I think I will end there, and thank you.
Thanks to all our speakers for their excellent presentations. I sure learned a lot, and it was accessible and helpful to me. But I want to say that these were dense presentations, and please feel comfortable listening to them over and over again to learn more about CLL, because there is a lot of content here. So feel comfortable reviewing them. These will be available. I also want to remind people that the Q&A is open. We've received a number of excellent questions, but we look forward to you submitting your questions. If you do see a question that's of interest to you, you can upvote it, and that'll move it to a higher priority. But please go ahead and submit the questions. Dr. Banerji can't join us for the live session, but we've been able to get a prominent last-minute guest to join our Q&A session. I'm really pleased that Professor Paula Ghia from Italy will be joining us. Dr. Ghia, Professor Ghia, is a professor at the University of Vita Salute San Raffaele in Milan, Italy, and the director of strategic research programs on CLL. He is an international figure in CLL, working with ERIC, which is an organization that you should know about, the European Research Initiative in CLL that is helping patients and clinicians manage CLL. We have approximately 20 minutes for the Q&A, so I'm going to get things started. And one of the first questions I'm going to do is direct to Dr. Gerrie to give us a sense of, you talked about vaccinations in today's day and era. We know about the COVID vaccine, but tell us, vaccines are changing. What vaccine should we get? What vaccine should we avoid in active observation or watch and wait?
Yes, hi there. Great question. Vaccines are a very hot topic these days. So even before COVID-19 was a big part of our discussions, we always talk to our patients about immunizations, particularly on active surveillance. CLL patients have an increased risk of infections as they are immunosuppressed, even when their disease is not very active, requiring treatment. So one vaccine is the annual influenza vaccine. We absolutely recommend that. Patients with CLL can have worse outcomes with influenza. We do recommend a pneumococcal vaccine or pneumonia vaccine, which usually has a booster about 5 years later. And then certainly with COVID-19, we would recommend the COVID-19 vaccination. There is data that patients with CLL also have worse outcomes with COVID-19. In terms of vaccines to avoid, live vaccines should be avoided in patients with CLL because of their decreased immune system.
And the shingles vaccine, the zoster vaccine?
Shingles, thank you. Good one. Yes, definitely shingles vaccine. And another point with CLL patients is being on active surveillance is the time to get your vaccines because a lot of the therapies that CLL patients are on further suppress the body's ability to produce vaccines. So all of the therapies that specifically target B cells are what are required to make a response to vaccines. And so if patients have had monoclonal antibodies like rituximab or obinutuzumab, there's a bit of debate about the exact timelines, but generally we don't think people can mount a good immune response for at least 6 months, possibly up to a year after those kinds of therapies. And then if people are on BTK inhibitors, those also impair their ability to make vaccines. So on active surveillance is the time to get all those vaccines, particularly shingles vaccines, which require boosters later on. And then other vaccines, which could be considered hepatitis series, travel-related vaccines. Again, before being on therapy is the time to get vaccines for patients with CLL.
Thank you for that. Maybe we'll invite Dr. Ghia with this question. There's a question about patients with CLL who have comorbidities, specifically diabetes, but also is there any link, because CLL is a cancer of the immune system, to other immune problems that people have, other autoimmune issues? What's the research on that and how does that guide therapy?
Yeah, thank you for inviting and thank you for the question. Indeed, there is no, though the CLL is a leukemia affecting the immune system, And though we well know that patients with CLL can develop, for example, autoimmune manifestations like autoimmune anemia or thrombocytopenia, still there is no relation with any major and more famous autoimmune disorders. And so this is not of a concern, and also there is no association with diabetes or and actually that is not really one of the comorbidities that should worry the patients and the doctors when starting therapy. Of course, nowadays thinking about BTK inhibitors and the risk of cardiovascular complications, in particular atrial fibrillation, the presence of diabetes is one of the many other situations like having hypertension, previous history of atrial fibrillation, age itself that can predispose a higher risk to develop atrial fibrillation. But I would not really have major concerns regarding diabetes or any other autoimmune disorders. In the era of PI3 kinase inhibitors, we knew that indeed some patients could develop adverse events like pneumonitis or colitis that were somehow due to an hyperactivation of the immune system. And in some cases, they even ended up having a very classic autoimmune manifestations in the gut, for example. So, but this is probably not so much relevant anymore, given the low usage of PI3 kinase inhibitor. It is true that new molecules are coming up, so we have to keep an eye and see how they will behave in this sense.
Professor Gerrie, can you remind us about what PI3 kinase inhibitors are and give us a couple examples?
Oh, yes. So the PI3 kinase inhibitor, the first one that appeared on the market and the number of patients have utilized is idelalisib. So they are, let's say, cousin of the BTK inhibitors, meaning that they are more or less impacting on the same pathways, on the same signaling pathways inside the cells. And they are as effective as probably the BTK inhibitors in terms of response, but indeed they had many more. They were associated with higher frequency of adverse events, in particular, as mentioned, pneumonitis, colitis, transaminitis, which means the elevation of the liver enzyme. All these manifestations were actually due to an hyperactivation of T lymphocytes of the immune system, which was somehow attacking the organs and the body. And as I said, idelalisib made it to the market. It has been utilized for many months, many years, and now probably, in particular in the US, there is a very limited usage, at least in the initial lines of therapy. Now a second generation of PI3 kinase inhibitors are coming up, and there have been a number of studies already exploring in phase 3, so in randomization with the standard therapy, their efficacy. It seems they are safer. We have to see, of course, with larger numbers and with the longer follow-up. One example is duvelisib, which I think is also approved in the US, while instead it's not in Europe, and others are indeed explored and will be probably available soon.
Dr. Lamanna, you just gave a nice talk about how you decide about therapy, but somebody wants to put you on the spot. And the question is, what's the absolute best treatment if you're 17p deleted and unmutated? And I have a sense of how you're going to answer this, but I want to hear your answer. Yeah.
Yeah. So, I mean, typically for sure, I think I made it clear in my talk that certainly those individuals really shouldn't be getting chemoimmunotherapy anymore for their disease. I tend to favor use of the chronic BTK inhibitors in that sense, just although venetoclax is extremely active and actually was one of the initial approvals was for patients with a 17p deletion. So it is also very effective therapy for those individuals as well. In terms of we talked a little bit about continuous versus time-limited therapy, and at least, we need longer follow-up from some of these studies that have been run, but at least when we look at, and remember, these are not randomized together comparisons, but when you look at the BTK inhibitors for patients with a 17p or p53 and are unmutated, they tend to do better over time, in the sense that when we're also then looking at the venetoclax-based time-limited therapy, it seems that there's a little bit of a drop off on the curve. And so although those groups do well with both of these excellent therapies, it might be that the 17P folks might do better with chronic continuous therapy. Until we remember, we are exploring these oral combinations together. So that might be something that might even be better for the super high risk patients. But I think we need longer term follow-up. So right now I tend to favor chronic continuous BTK inhibitor based therapy for those individuals.
Dr. Gerrie or Gia, did you want to add anything to that?
Yeah, well, I fully agree, 110%. And the issue really is that it's true that we have both BTKIs and venetoclax continuous therapy available for these patients. In Europe, they are approved and available, for example, sequentially, meaning that the first choice is BTKI. Unless you for some reason you are intolerant to that and you cannot start for any reason, then you could use venetoclax continuous therapy. So at the end, the real choice is really the BTK inhibitor, and probably is the one for which we have the longest follow-up in first line, because we have now 6 years of follow-up, really showing that these patients are responding as good as well as all other patients.
And I agree. I don't have anything more to add. Same comments.
Dr. Gerrie, and others can kick in on this too, is one of the biggest complaints from patients with CLL, and even in the active observation period, is fatigue. What do we know about the causes of fatigue in CLL, and what can a patient do about that? Or is there a workup that you have to do? How can you help your patients with fatigue?
Yeah, that's a great question. Certainly a very common thing that we see and hear about from patients. Fatigue is really challenging because we all know there's many reasons for fatigue. And I think the first thing is to try to sort out if there are any other contributing reasons to the fatigue. So a usual workup for that usually includes screening for other conditions, thyroid issues, and then things that are not necessarily easy to screen for. There might not be a specific test, but certainly to talk to patients about stress, fitness, exercise, all of these things, sleep habits that can contribute to fatigue. The bottom line, though, is we also know CLL itself can cause fatigue. And so, you know, it's a very common symptom that patients have, and often we're trying to determine, is it the CLL or is it something else? In terms of what the relationship is between CLL and fatigue, I'm not sure we really know. There are some questions or some thoughts that it might be related to what are called cytokines released by the cancer cells. Cytokines are sort of like enzymes in the cells that can be released when cells are active. I'd be happy to hear from my colleagues if they know of any other specific mechanisms, but this certainly is a challenge for patients. I think trying to maintain some form of active activity or exercise can certainly be helpful for fatigue. Making sure there aren't other causes like thyroid, iron deficiency, another common reason for fatigue, or other chronic comorbidities, and then really those sleep habits and stress and mood kind of management can all contribute and help.
Anyone else want to chip in, or are we good to go to another question? Go ahead, Dr. Lamanna. Yeah.
This is really tough. You know, obviously, I wish we could have a better handle on when we've excluded other causes, if there's something we could give or administer to patients. And there have been some groups who have looked at trying to administer some oral agents to try to help ameliorate with fatigue. But it's one of those things that unfortunately, you know, we really do need to look into better. And in fact, sometimes we even see disproportionately that women have more fatigue than men with CLL. And so I don't know if that obviously differences between obviously men and women and hormones and other factors may come into play as well. but it's a really challenging issue that we face. And of course, we don't like to just initiate therapy based on fatigue if everything else looks okay, which of course is really difficult for patients to hear. So I think it's definitely an area where there's one unmet need of trying to see if there's something else that we can do for patients who might be on active observation but have fatigue and otherwise have no other reason to have fatigue. But it's a complicated picture because as we noted, there could be many reasons why patients have fatigue in addition to their cancer, and that makes it even more challenging to deal with.
Yeah, if I may add something, they already said everything. I might say something very practical for the patient, because indeed, first of all, I always clarify with my patients what fatigue means, and in particular, the leukemia-related fatigue is. So I had another patient a few days ago. He came to me and said, "Oh, look, I have so much fatigue since I've been diagnosed. I wake up at 6 in the morning, and then around 6 in the evening, when I'm still at work, I feel fatigue." I said, "Good for you. I don't wake up so early and I already feel fatigue." So meaning beside the job is not the tiredness that accumulates during the day. That's physiological. And unfortunately, that increases with time and aging. So the longer the patient stays on diagnosis and the longer we feel fatigue at the end of the day, because we are also getting older. So fatigue, the leukemia-related, like cancer-related fatigue is something completely different that we are not used to experience, that lasts similarly during the whole day. And usually when patients experience the real fatigue, they always tell me, "Professor, I understood what you meant. It's something that I never felt before." And this is, again, to reassure the patient, it is highly associated with the bulk of the disease. So as Professor Ramana said, I mean, if the disease is not progressing, if you don't have large lymph nodes, if you not becoming anemic, which is also another reason of fatigue, it's very difficult that the leukemia can give really fatigue. So it's really helpful to think that you must see your disease progressing and bulky, let's say, so that you can explain what you're feeling as leukemia-related fatigue. Otherwise, there are many other reasons. And definitely, I would never treat anyone for the leukemia just based on fatigue.
It's interesting. It's always tricky to sort out. And one of the members of one of our support groups said, when he had some symptoms, he says, I don't know what's the cause of this, because I've never had CLL before, but I've also never been this old before. So it's like, which is causing this symptom that I have? There was some early discussion. Dr. Banerji talked a little bit about the difference in different ethnicities. Is there different disease evolution that we know about in different, there's all this data about clonal evolution and how the cancer changes over time. Do we know anything about whether that's different in different countries? And are there environmental factors, or there different therapy choices that might affect that disease evolution? And I'll let anybody jump in on that. And so is there an ethnic difference? Are there things that patients can be doing environmentally? What do we know about why some people, seem to stay relatively stable, and other people, their disease evolves, and usually in a bad direction? Nicole, I'll ask you to start on that and get going.
So that's a good question. The environmentally, I think certainly there could be, right? So, but usually, we would take that into consideration in the sense that there's no doubt that I think that folks who, let's say, here in the United States, for example, 9/11 is a prime example of that, where, certainly, increased risk of cancers, including CLL, have occurred. And I think the biology then will bear out. So some of the testing that we do on patients' baseline features, if there's been an environmental exposure and they wind up having a TP53 mutation, I think, you kind of know what the biology is if they're more aggressive and maybe they were exposed to a major environmental issue. And certainly that can contribute and then would speak in line with the biology of their disease accordingly. Ethnic wise is a little trickier, and maybe my colleagues could speak up, because, I have to say that my clinic practice predominantly, although I do have It is rare in the Asian population for sure. Whether they do differently is I'm not sure that's necessarily the case, because it would really be based on the biology. So, it really, as far as I know, we're really going to still think about how patients progress or how aggressive their disease is based on the biologic prognostic markers that we still currently know about. And I'm not sure if anybody has looked at, with other ethnic groups, how, the decreased in frequency of different prognostic markers are. Paolo, do you know if there's, because I'm trying to think if there's really a difference, based on biology?
Yeah, we did several works with Chinese and Japanese colleagues, and they are rare, but at the end,
the biology is
major differences. We are now discussing about stereotypy, which might be indeed different, because that might be related to environmental factors, meaning like bacteria or any infection or inflammation that can occur. So maybe that's a new path, but it's really something very, very, very preliminary. We cannot really talk about that. But
can you explain that in a patient-friendly way? Stereotypy.
Yes, that's very correct. But first of all, I wanted to say something about ethnicity, which is interesting. Maybe people didn't hear before. I heard only recently that when you look at the frequency of CLL in Latin America, in South America, it's really astonishing that the indigenous people, the native people who are originating directly from the Asians, because through the Alaska, they came down, they have very low frequency of CLL, while instead all the European immigrants, they have exactly as we know, the same frequency that we have in Europe. So that's very interesting, again, suggesting that there is something genetically driven there. So about stereotypy, sorry for being too technical. There are, we already described many years ago that there are patients who share on the surface of the leukemic cells the same receptor, the same immunoglobulin, the same antibody, which is recognizing then similar or identical objects, which typically might be bacteria or virus or fungi, or also self-antigens, so molecules that are present on the cells, on our own cells. So one of the theories that indeed there might be some infectious agents that could drive the growth and the expansion of the clone. So this is not due to an acute infection that you might have yesterday or 1 year ago or 2 years ago. There might be probably a chronic stimulation of some virus chronically infecting our body. But this is again very preliminary, very it's a hypothesis that has to be explored experimentally. Yeah.
We're out of time. I certainly want to thank Drs. Lamanna and Gerrie for an excellent discussion on this panel. And please continue to listen, because you're going to have a great topic coming up, a very important topic coming up, which this bridges to, which is managing emotional and psychological challenges of living with CLL. And I'm going to pass on to Charlotte Martin, who will be moderating this panel discussion. Charlotte, please take it from here. Thank you to everyone.
Yes, thank you, Brian, and thank you to our previous speakers. That was a really interesting discussion. As Brian said, we have heard a lot already today about how you manage CLL, how you treat it, how you medically to deal with CLL, if you like. But we've got really interesting and equally as important, I feel, discussion to be had this afternoon. And we've got about 30 minutes left now to do it. Just to start by introducing myself. So I'm Charlotte. I'm the Patient Advocacy Manager at Leukemia Care in the UK. That's one of the charities for blood cancers there. And also to say before we start that Dr. Johnny Rains unfortunately is unable to join us today, but we have a great other panelists still with us, and I'm sure we can still have a really good discussion. Just a reminder to pop your questions in the Q&A at any point during the chat and during the session, sorry, and we will try to come to those as we get to the relevant topics. So without further ado, let's introduce the panelists we have got. So I'm pleased to say I'm joined by Anne Crook, who's a counsellor and psychotherapist working in the psycho-oncology service at the Christie NHS Foundation Trust, which is in Manchester here in the UK. And she's keen to put some of the psychotherapeutic interventions for people affected by cancer into practice. So hopefully she'll have some really interesting stuff to share with us about CLL. I'm also joined by Jan Rin. Jan is a CLL patient diagnosed in 2011, but realised early on that she needed to be an active participant in her CLL treatment, and eventually that led to her becoming the co-founder of CLL Ireland in 2017, where she's currently a trustee and a chair. So thank you for joining us, Jan. We're also hopefully going to be joined by Pierre Aumont as well. There he is. Hi, Pierre. Pierre is also a CLL patient diagnosed in 2011, currently on watch and wait, excuse me, and also an active patient advocate, including the vice chair of the CLL Advocates Network, who have organised this wonderful conference for us. So thank you to the three of you for joining us this afternoon. So without further ado, so I'm sure we have quite a lot to cover. I wanted to start by discussing with you guys what the challenges are for CLL patients. I'm sure most of the people listening are either patients or working with CLL patients, but it's always good to start with some basics. And I thought maybe our patient speakers may be able to help us first. Maybe Jan, you could to speak to this point. What are the challenges you have faced since your diagnosis and beyond, and how have they changed as well? Would be really interesting to hear.
Yeah, hi Charlotte, and hello to my fellow panelists and everybody out there. Yeah, so a diagnosis of CLL, it's heavy stuff. And I guess, you know, the fact that it's a chronic cancer and we're going to have to live with this and manage it at various junctures in life, and, you know, it runs with the life course. That's the real key in you know, the challenge it presents, because it's not just one challenge. So initially, you know, at diagnosis, there absolutely is an emotional impact and a psychological impact to that. And I suppose then there's a process of, you know, coming to terms with what this might mean and how life might change. And depending on the patient, it's, you know, it's going to potentially impact family members, employment, all of those things that we all have to manage in life. And, you know, doing it with a chronic illness is pretty daunting. And then, of course, we've got, you know, if you're in a watch and wait situation, I know Pierre can probably talk a little bit more about this. You know, there's a challenge there. And then once treatment begins and working through treatment and beyond treatment, and some of us are still on treatment. So for me, I'm still on treatment. I'm since 2014, and that comes, yeah, absolutely comes with challenges. So as if all of that wasn't enough to contend with, then you know, there was a pandemic. So any of those skills that we thought we had picked up and learned how to manage our disease with have definitely been tested of late. And so I think, you know, we can't talk about the impact, the emotional impact or the psychological impact of CLL without talking about COVID. Unfortunately, it goes hand in hand, and some of us are feeling isolated potentially or separated from society. And I think it probably highlights that feeling of isolation probably, you know, was there before COVID, because you're a little bit different when you've got this disease and you've got to figure it out.
Great, thank you. I think what you've highlighted there is we often talk about these challenges as being dependent on where you are in your pathway or your journey. So whether you're a watch and wait, whether you're on treatment, that sort of thing. But you've highlighted the pandemic is one of the examples, is something that affects you regardless of where you are, a more external factor that might influence your emotional, psychological states. That's really, really useful to hear. Pierre, is there anything you'd add in terms of what your challenges have been, or those of people you may know in the CLL community?
Well, if you want, I will use my own example. As a watch and wait patient, I have been diagnosed 10 years ago, so it's a long. I am lucky enough to still be in watch and wait. But when you are informed that you have CLL, which means a blood cancer, you will have in mind this is a cancer, point one, and this is a leukemia. And if you refer to what you can have in mind through the information you can get, cancer, well, more frequent cancers, breast cancer, prostate cancer, etc., or leukemia, for instance, acute leukemia for children, for instance, you may think the earlier I will be treated, the better. And it is absolutely false. So it's a huge error to think that you might need a treatment as soon as possible. That it's not the case for CLL. Perhaps for some very high risk patients, depending on their personal parameters, etc. Maybe they will be treated at once. But for, let's say, at least 2/3 of the patient, and if not 3/4 of the patient, they have to wait. And wait doesn't mean worry, even if you have to be tested, blood works, etc., every 6 months or 9 months, depending upon the situation. Of course, it brings stress. No question about it. It is a stress. But indeed, I always say in CLL, you might have in mind chronic, more than leukemia or cancer, because if you wait, you can benefit from the huge improvement of the treatment that are in place now. I am dealing with these issues with the CLL patient advocate for more than 5 years, and within those 5 years, we went from chemoimmunotherapy to targeted therapies, and now combinations. So the more you can wait, the more benefit you can get from the huge improvement of the treatment. So as a patient advocate, you have to inform your patient about this situation. Don't worry. It's not watch and wait. It's not watch and worry. It is rather active. What the new term is better than the old one. I don't remember. Active.
Monitoring, surveillance. I think people use different words, don't they?
It's not monitoring, but never mind. So you have to inform the patients about that, and you have to make it possible for the patient to exchange with other patients, so kinds of forum, etc. It's quite important. Of course, it's nothing like a person being treated, but it's stressy enough in order for the patient advocate to make in place all that is important for the people to be informed and to manage their own disease.
Great, thank you, Pierre. I wondered, Jan, whether you wanted to respond, because I think Pierre's put a great case across there for watch and wait being a particularly bad time for most people. And as someone on treatment, did you want to sort of come back and maybe put a case forward for the treatment period and whether that's difficult for you as well?
Yeah, absolutely. Well, I suppose my own personal experience was that I didn't have very long in watch and wait. By the time I was diagnosed, I was pretty symptomatic and it kind of escalated fairly fast. So I think now when I say that, I tried lots of kind of smaller treatments or shorter treatments before I got onto the longer chronic therapy that I'm on now. So yeah, those first few years were there was a lot of decisions to be made. So a little bit like we all kind of feel now, a little bit fight or flight. It seems to be an extended period of that. Like Pierre, I'm 10 years diagnosed. So I think 10 years ago, the expectation was that the treatment would follow fairly soon. And actually, I think, Pierre, now you and I, know so much more about that active surveillance period. And I would definitely advocate for it if a person is medically suitable for that. For that exact reason that therapies are developing, and if there isn't something that really pressing that has to be treated. So yeah, I think that there's pros and cons to both. I will admit to feeling very relieved when I started treatment. I will admit to that, but I think that probably was an indicator of how heavy the disease burden was at that point. And I didn't feel better fast enough for me. I wanted to feel better yesterday. So I would have done anything. But I definitely see Pierre's point. There is definitely a case for waiting if you can.
Great, thank you. And this is probably a good place for you to come in as the professional voice. So we've got the paradox of watch and wait for CLL, and then we've got the treatment. What are those? Are the challenges you see in your patients reflected in the challenges that Pierre and Jan have already outlined for us? And if so, what do you say to those patients to help them through those periods?
Yeah, thanks, and hello everybody. And I think listening to you both, Jan and Pierre, I suppose I'm struck by the differences and how this is always going to be a very individual experience. And I think I kind of want to do a little bit of a shout out for the people who are very newly diagnosed and still kind of reeling from the shock and still trying to come to terms with this diagnosis of, as you say, Pierre, a blood cancer, and cancer in itself is a very scary thing to be diagnosed with. So I think there's something around sort of like just that vulnerability that people will experience early on in the diagnosis. But then I think, what you've illustrated really well, that it's so important to kind of like to be educated and to get good education from particularly the teams looking after patients, but also for what always strikes me about CLL is this incredible network of peer support, more than any other kind of cancer that I work with. So I think a common theme is often the uncertainty. So the uncertainty that comes with active surveillance or active observation, I think I heard described earlier. But I think most of us still think about it as watch and wait. And I really like what you said, Pierre, about thinking about, well, the longer you wait, the more chances there are of these novel therapies coming online. But I think for many people, it's still watch and worry. And how do we manage that uncertainty? And trying to live life and continue to live life with this chronic diagnosis, but knowing that things might change, as you described, Jan, getting onto treatment and then all of the challenges that treatment brings. So I think, there's no one straightforward answer to this question.
I don't think there is with anything to do.
Charlotte, but
that's fine. I was about to say I don't think there's anything straightforward about anything related to CLL. Is what I've learned in my few years in the area. Let's come on to when people should seek help for if they're having emotional or psychological problems. And I wanted to come back to you very quickly, if I may, in terms of when people should seek professional help, in particular from someone like yourself. What's your view on that?
Okay. I mean, we human beings are incredibly resilient, and we adjust and we adapt and we process what's happening to us, and we do learn to live with whatever challenges life comes our way. Although, as you say, in this time of COVID as well, it's really challenging for many. I think the time to seek help is when it has an ongoing impact on day-to-day living. So, when we begin to think about our mental health, we think particularly around anxiety and how anxiety can really stop us doing things. So I think one of the challenges living with chronic illness is to kind of try to perhaps redefine or re-identify goals and be able to plan. But anxiety in particular can stop us making plans, can stop us doing things. So if it really gets in the way of doing things, then that might be a sign that actually some help may be helpful. And low mood as well can, it's bound to be we're bound to feel sad and low sometimes, particularly struggling perhaps with illness, particularly struggling with fatigue, which I think is a really difficult challenge for trying to live with CLL. But fatigue can bring down the mood, and then it can stop us enjoying things, and we lose any motivation. And again, that might be time to seek help. Or if you really want to just kind of have somebody who isn't so involved, somebody not so close to you or neutral or not involved necessarily in your medical care, just to kind of talk things out and sort of say, actually, where am I with what's happening to me?
Yeah, lots of different scenarios there to consider if you're looking for support. Pierre, did you want to comment on what Anne said? And also I was going to come to you to say what helps you deal with your situation.
I was really thinking the most important is not to leave the patient alone with his disease. So it is the most dangerous, especially for this kind of disease. You can say, well, that is the treatment. We already have seen in the different lectures how heterogeneous this disease could be. So there is no one solution, one figure, or whatever. That's not the case. And what is probably what may happen with the patient is that they have no human-driven contact with their clinicians, and that could be, of course, improved, and that is becoming better and better. And we, as patient association, patient advocate, could, of course, give information to the patient, give also information about the specialists, CLL specialists. Some of the patients are in contact with hematologists that are not really aware of the new improvements about CLL. So that's quite important indeed, but never replace the clinician. That of course, for a patient association is absolutely key. Never replace the clinician, and if necessary, give advices about a clinician that could be contacted or whatever of this kind, but never replace clinicians. And if necessary, you can advise also a psychologist and not only hematologist. If really the patient is in a huge distress, I mean.
Thank you, Pierre. And Jan, did you have anything to add? Maybe not just from your personal experience, or that would be fantastic, but also a little bit about how, for example, you maybe in CLL Ireland support other patients. What sort of, someone's asked in the Q&A, what sort of services do groups like CLL Ireland offer? Would you mind just touching on that as well?
Yeah, well, sure. Well, I suppose from an organizational point of view, COVID has impacted us because we're, a small patient-led charity, volunteers. Before COVID, when we were able to have our face-to-face events, we regularly surveyed our audiences. And what was really interesting at that point, and I have no reason to think it's different now, is that whilst a lot of people in the room were there to hear medical updates on their disease, a lot of people were in the room for support, emotional support, that feeling of connection with somebody else. Some patients had never met another patient with CLL. It was so important to them to and the cup of tea was sometimes more important than, although the doctors were brilliant, but sometimes almost more important than the medical sessions. And I think really we can't talk about one without the other. They go hand in hand. So, and when we're talking about emotional support and psychological support, I think we need to talk about what that might look like. So for some people, it might be visiting somebody like Anne. For others, it might be that cup of tea, with another patient. And I suppose there is another level, severe anxiety, psychological issues that might need to be treated with somebody in a hospital situation, a psych oncologist or somebody like that. I know that some other organisations in Ireland offer some counselling around cancer. And I think we have a challenge as CLL patients. I've spoken to patients who feel like it's almost as though they're not eligible to utilise that service because it's not a real cancer, or they're not going through chemotherapy potentially, or they don't feel bad enough. And so we've had a huge challenge in our group in kind of, getting that message across that, it's cancer. It's cancer. It's a chronic cancer. It's definitely not a good cancer. This is not the message that Pierre and I would have received a decade ago. Hopefully clinicians have stopped giving that message now that it's a good cancer. And so there's that whole piece around finding where you fit in on this. And the other thing I wanted to say, which is, I know it's not an answer to your question, but I didn't want to let it go, was yes, there's the patient, and the patient is in the center of this, but no man is an island, and families are affected. And, back to kind of the personal experience, when I was diagnosed, I had 4 children under 11. And I opened the booklet I had been given in the hospital about CLL, and under the title, how to tell your children about your diagnosis, it said, the chances are if you've been diagnosed with CLL, you're older and your children are adults. And, I'm looking at these 4 kids who hadn't got a clue. And how do you, we figured it out, made loads of mistakes along the way, undoubtedly. It's not one conversation. It's still a conversation, unfortunately. And COVID has changed everything. So now it's a daily conversation. So I think, yes, the patient needs support, and then the wider family unit, and what's this going to look like for our family? And as a mother, I hate the word, but I'm going to say it, guilt. There was so much guilt about the fact that I had this diagnosis. It was going to impact my kids, it was going to impact us financially, emotionally, all in every which way. So I think, I think we've moved on a little bit, and that there are some supports out there for children of parents who've been diagnosed with cancers. Ireland still has a way to go. I think it's something we really need to talk about. And that message then for kids, they hear about cancer and they hear about people dying of cancer. And when my kids were younger, I had to keep telling them it's not the same cancer. This isn't, your friend's granddad who died of cancer. This is different. We're going to figure it out. We're going to live with it. We're going to thrive and survive. And that's really nuanced, that piece. And there's no one fit for everybody. This is something that every family has to. I know patients who haven't told their children, and I absolutely wouldn't judge that either. And until they're about to start treatment. So I think everybody, but it's about giving patients the empowerment to know that they can make those decisions and they have those choices. Sorry, I waffled on a bit there.
No, not at all.
I went off on a tangent. Sorry.
No, I think it's really good to bring up the patients, family, friends. It goes so much wider than as you said, the person in the middle. And did you have anything to add on the family and friends side in terms of do you often see patients who tell you that their friends and family are also struggling, and can you provide that wider support in your service, or is it a challenge to do so?
Well, not in my service, and that's a loss, I feel, because I absolutely agree. I mean, I many years ago, somebody came to see me and she said, well, my husband's been diagnosed with leukemia, but I've got leukemia too. And I'll never forget how, we were thinking about the relationship, and we were thinking about the fallout, that it does affect everybody. And I think that can be sort of almost more difficult somehow for family members when the focus of attention is on the person with the diagnosis. But actually that partner or other family member or kids might be feeling really that they're struggling. So I absolutely agree with you, Jan, that we need kind of more appropriate support for people who need it, and I think we know a lot more now than we did even 10 years ago about the impact of illness in the family on children and older teenagers, and we're trying to sort of like do more thinking about that in a kind of with the whole picture in a more holistic way. But I suppose the bit that I want to get in is that your advocates, your patient advocates, and please, 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 wherever you are, do your advocacy for more services to support the psychological needs of people affected by CLL, but also all cancers, because it's very unfairly distributed. So, yeah, that's absolutely. I won't get political.
Perhaps we can come back to challenges accessing support very shortly. But Pierre, did you want to jump in there?
Yes, I wanted to point out an issue that is very often scary for the patient. Should they inform their employers? Should they inform their bank? Should they inform their insurance? Because, if you have a cancer, if you have a CLL, you won't be treated as an equal customer by banks and insurance, for instance. And I have to say, we tried in France to discuss with the insurance syndicate and succeeded at least to get normal treatment for the customers for, let's say, less risky types of CLL, for instance, mutated IGHV or TP53 mutation, or not all the risky parameters. So we succeed at least in this direction. It was a very hard discussion, but really it could release some patient of this difficult issue to be properly insured and properly treated by the bank, for instance, or by their employees.
Some really interesting points there. I've certainly heard insurance discussed here in the UK as well, and employment is something we hear all the time. So yes, I totally agree. Those are really important issues. Just want to actually answer the question that was asked, if you like, with a bit of advice of my own. So the person's actually asked what services can advocates offer, and I think if you aren't sure as an advocate what sort of things that are needed in your patient community, is one, to ask them, and then two, look at what others in the clan, the advocates network, are doing, because there's some really good initiatives out there. And Jan's already spoken about conferences and meetings and things like that, and those sorts of things. There are plenty of examples to use. So that would be my advice, just to sort of pop in there, even though I'm not on the panel. So back to you guys. We're actually very fast running out of time, so I'm going to make this the last question. What I wanted to talk about as advocates on the panel, we talk often about how we can support patients who are already diagnosed, who are already feeling quite awful. But Jan, is there anything that we can do to prevent some of this harm from CLL in the future? So, for example, you talked about people describing it as a good cancer. Is that contributing to the harm? And is that one example of how we could possibly prevent some of this psychological damage to patients in the future?
Yeah, absolutely. I mean, that is one example. And I think we're probably starting to see some differences happening. So I think conferences like this are brilliant because, it's bringing together advocates primarily, but we also have the opportunity to listen to some really strong clinicians, and I'm assuming that they will benefit from hearing from us too. And I think that that's really good because, given everything that they might have to deal with, perhaps they are not necessarily thinking about the emotional space of the patient when they're delivering news, for instance. I think there's a really important role for the cancer nurse specialist or the clinical nurse specialist. And in an ideal situation, they potentially would point the patient to a medical social worker who might be able to address some of those issues around potentially employment or financial assistance. And again, speaking in an ideal world, wouldn't it be great if at that point there was some signposting towards some psychological support? I know that's not happening in Ireland at the moment. I would, if I could wave my magic wand, it would be one thing, but I think would be brilliant for patients to be able to access. And there's, we have to think about it. We can't pay for it all the time. So there's a financial barrier there to that. I can't speak for other countries, but certainly here we have a two-tier healthcare system. So, you can access psychological support if you can pay for it. And not everybody's going to be in that boat. And I suppose the extra challenge of being diagnosed with a chronic cancer, surely would impact most people in terms of concern about their finances. So unless it's a glaringly obvious wound, they're not going to go and seek out a way to spend more money by dealing with their emotional health. But I think they should be encouraged to, because this, as Anne said, there's a holistic approach that needs to be taken here. And I think, again, when it gets to the treatment juncture for patients, it would be brilliant again if they could be signposted. It's about just feeling that they're in the right mental space to make a decision about their treatments. And I suppose the patient advocacy group, from our perspective, we see one of our roles as being we're in that place where we're hopefully helping patients to become empowered for themselves, to just take on the information. Some of it's really complicated. They don't have to learn the science of it, just to know what their treatment options are, so that they feel that they have a contribution to the decision. Actually, I know there's a session coming up later about shared decision making, which is kind of sliding into that a little bit. But that feeling like that they're contributing to their own care, and I think that actually helps mental health. It helps a patient to feel empowered.
Thank you, Jan. I think that's a really great place to end the session. Pierre, very, very, very quickly, as we're out of time. I don't want to be told off.
just to mention, there is a huge discrepancy between the different countries about availability and reimbursement of the treatments. So it is our job as well as a global association to help the association of the countries where the drugs are not available or not reimbursed to lobby in the direction of their health authorities.
Perfect. Thank you, Pierre, because that really leads us very nicely onto saying there is now going to be a break until 22 the hour. I won't say which hour because everybody's in different countries, but 40 minutes past the hour, please return, approximately 30 minutes, where you'll find an advocacy session beginning with, I believe, with evidence-based advocacy, which if you're wishing to make some of the changes that Pierre and Jan described there, then you'll find very, very useful. Thank you to my panelists for today's session. Thank you very much.
Thank you.